Good morning, everyone. How are you this morning? On our last day of this conference that has been absolutely fantastic, with the great speakers and presentations and everything. And who can forget International Night this year? It was really good. Just a few housekeeping announcements. Certificates of participation will be available at the registration information desk. They will only be distributed during the breaks. So if the session starts, we will be closing it down because we want everybody in the sessions, okay? The airport shuttle, for those who are returning back on Saturday and Sunday, the airport shuttle will start at 6 a.m., and the final one will leave at 6 p.m. On Saturday, it will be every half hour, and on Sunday, it will be every hour. If your flight leaves prior to those times or after, we suggest an Uber, or the hotel can then get a taxi for you, okay? Just a note for those who are staying here tomorrow night, Saturday night, the United States goes off daylight savings time at 2 a.m. on Sunday morning. So what we encourage everybody to do is to fall back an hour. So if you are going to bed at 10 p.m., you're going to want to reset your clock to 9 p.m., okay? Because as of 2 a.m. Sunday morning, all the hours in the United States change, okay? If you are going to be attending the program directors meeting, you will be receiving an agenda today by email. I apologize, we had some last minute changes due to a family emergency of one of the speakers. And we are also going to be sending out a conference survey at the end of today. And we really would love your feedback for us to make this conference even better, what is working and what is not, so that way your experience will always be enjoyable at one of our conferences. So please, please, please respond to it and send it back to us. Thank you so much.
Good morning, everybody. I hope you're doing well, and I hope you're enjoying the conference. The easy way to remember, I was also very confused about the clocks. I could never be sure if they're turning forward or back. So the trick I learned, I was told, was that in the fall, the time falls back 1 hour. In the spring, it springs forward 1 hour. So turn your clocks back an hour, don't forget that. Okay, I'm honored to introduce Dr. Babatunde Olowokure this morning. He's based at the World Health Organization Emergencies Program in the Department of Health Emergency Information and Risk Assessment. Dr. Babatunde Olowokure was appointed Chief Health Emergency Information and Risk Assessment Department Program in September 2018. He is a medical doctor, epidemiologist, and a trained public health practitioner. Prior to his appointment, he worked in the WHO Western Pacific region, where he had particular responsibilities for managing the surveillance, alert, and response capabilities of the regional office, with a focus on supporting member states to identify, assess, report, and analyze data related to epidemic-prone disease, outbreaks, and public health emergencies. During this time, he played a key role in developing and implementing the Asia-Pacific Strategy for Emerging Diseases and Public Health Emergencies, APSED3, and for managing the Regional FET Fellowship Program. From 2013 to 2015, Dr. Olowokure served as the first director of surveillance, disease prevention, and control of the Caribbean Public Health Agency and established the agency's regional global health security program, where he supported the development and implementation of the Caribbean Regional Field Epidemiology and Laboratory Training Program, as well as developing and advancing partnerships and collaborations with countries, bilateral organizations, and public health agencies within and outside the Caribbean region. Dr. Olowokure has been professionally involved in public health, epidemiology, surveillance, and response to public health emergencies for more than 25 years. He has worked in a variety of countries and settings in Africa, Asia, the Caribbean, Europe, and the Pacific. Welcome, Dr. Olowokure. Please, could we have a round of applause?
Okay. Good morning, everybody. Thanks a lot, Carl, for that great introduction. I almost didn't recognize myself. So is this the... Okay. Okay, great. So I'd like to thank TEPHINET and the organizers of the conference for inviting me to give the keynote speech, presentation on the last day of the conference. So I hope everybody's still awake and listening, especially after the festivities that have recently happened with regards to the International Night. So the picture that you can see in front of you is a WHO worker standing on a hill overlooking the city of Goma, which is the third largest city in the Democratic Republic of the Congo, and I'm going to shorten it to DRC for the rest of this presentation. And this city has a population of over 1 billion. The relevance will become clear later on in the presentation. But the presentation I'm going to give is titled Health, Borders, and Population Movement, and Geospatial Analysis for Public Health Emergency Preparedness and Response. I'm going to divide my presentation into 6 components, as you can see there. So give you a sort of a brief introduction into the presentation, talk about some historical aspects of population movement and disease, and then also look at global air travel and the spread of disease, which brings us more into the modern era, and then also give some idea of, or give an example to illustrate health, borders, and population movement, give you some public health action points arising from that illustration, and then provide you with a very brief summary. So what do we have, or what do we see in the world today? The movement of populations over time has actually shaped the pattern and distribution of infectious diseases globally. The reasons for population movement are very complex, and they vary from forced to voluntary movements, temporary to long-term, short to long distance, and internal to cross-border. They may also be socio-economically driven or seen as an action of last resort for those enduring conflict or as a result of a humanitarian crisis. In the context of disease outbreaks, population movement is a known risk factor for the spread and amplification of diseases. So the consequence of these movements are seen in both the places and the populations visited and may persist for decades or even longer. So what I intend to do here is just to really provide an overview, given the time that we have, with regards to population movement and how it affects the distribution of some diseases, and then also demonstrate how geospatial analysis can actually help and support public health emergency preparedness and response and decision making. Sorry, can you click on the link, please? I only need 17 seconds.
Cause disease are known as miasma. The miasma spreads through the air, and as it is breathed in, the human being becomes possessed of sickness.
I'm not sure that's how it works.
You know nothing, Jon Snow.
Okay, you can stop. Thank you very much. So this Jon Snow knows nothing. Okay. But this Jon Snow knew a lot. And he's lauded as the father of epidemiology and the pioneer of disease mapping. So Jon Snow, from the outbreak of cholera, which happened in London, Broad Street, which everybody is very much aware of, presented this map. He didn't actually draw the map himself, but he presented this map and showed the distribution of cases by household. And each of the small bars on the map itself represents a death in each household. And so this actually is often cited as being an example of one of the first examples of using geographic inquiry to understand a health epidemic. So yesterday was Halloween, trick or treat, and the relevance of this is that in regards to travel, when people travel, they carry things with them. So they may carry gifts or they carry diseases. And so we have a situation here where history has told us that travelers often take diseases to non-immune populations. So over time, we've seen measles, tuberculosis, and plague being carried around the world. This gives sort of a historical aspect or flavor to the talk. And this actually is a ship which birthed in Genoa and was carrying, well, let's say most of the sailors on the ships had died, and it was coming from a port in Asia where the plague had occurred. And it came from a port in the Black Sea, and hence the name that we now have, which is the Black Death. Now, this particular disease circumvented most of Europe and also Asia, and decimated the populations of Europe. And there was an estimated mortality of 50 to 70%. And the point of interest here really is that this type of population movement was associated with trade, and therefore the carriers of the bubonic plague then infected people along the way, and the plague then moved across, as you can see, various continents. And it took several years in order for this to happen. However, nowadays, we have air transport. And this actually has helped us to get to places faster, go further, and actually carry more. But this also pertains to the various pathogens as well, and also animals and plants that also may be carrying disease. And so therefore, this actually has consequences for our own preparedness and response with regards to public health. Now, this particular graph shows the number of passengers carried per 1,000 kilometers, and as you can see, it's increasing exponentially. So this means that every 15 years, the actual number of people carried is doubling. And this, of course, again, has other consequences apart from the ones we're talking about here today. And this, again, is just to illustrate that. So travel is now vast and rapid and rising, and a significant risk factor for infectious disease emergence, as we're all aware. So humans can reach any part of the globe now within a few hours and within the incubation period of any disease that they might be carrying. We should also remember that people don't just go to their destination. I'm sure many of you who flew here may have had transit stops along the way. And this again provides another window of opportunity for emerging diseases to infect non-immune populations. The poster disease, or the disease that many of us will be aware of, is Sars. And this occurred in 2003, with first case identified in 2002. But the seminal event was, of course, the hotel in Hong Kong, where the many participants came from various countries, went back to their home countries, and then infected other people. And this only took a matter of days. And as we can go further, faster, these sorts of events will continue to happen. There are numerous other examples. More recent, of course, is the pandemic influenza H1N1. But we shouldn't, of course, forget the various vector-borne diseases as well, such as dengue, chikungunya, and Zika virus as well. And although the focus here has been on air travel, other conveyances are also potential carriers of people with disease as well. So this brings me to the IHR, or the International Health Regulations, the revised 2005 version. Now, the purpose and scope, and I'm going to quote, of the International Health Regulations are to prevent, protect against, control, and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks, and which avoid unnecessary interference with international traffic and trade. End of quote. And so the IHR provides a legal basis because there are member states, or states parties as they're called in this particular document, all signed a legal obligation to adhere to the tenets of the International Health Regulations. And the International Health Regulations contain a number of documents which are relevant to international travel and trade, and also in relation to travel and transport of goods as well as people. And so they provide guidance on ports of entry, and those ports of entry are usually at airports, seaports, and ground crossings. However, as we all know, borders are not watertight, and people will cross them for various reasons and may contribute to the spread of disease, particularly if they are asymptomatic or incubating the disease at that time. So we also know that they will come across when they're ill as well, and we saw this very clearly during Ebola 2014. In May 2015, the World Health Assembly asked WHO to review its conduct for the 2014 West Africa Ebola response, and a review committee was established, and that review committee provided some recommendations, and amongst those were that the IHR as a tool itself should be kept as it was and did not require any change. But the committee also concluded that the implementation of the IHR needs strengthening. And so there are various core capacities which are associated with the IHR, and these include surveillance, the ability to respond to public health events, and this is an all hazards one, and also the ability to communicate the findings or conduct a risk assessment as well. So they also said that points of entry should be seen as places of vulnerability as well. And so there is a need to also strengthen the points of entry as well as the core capacities. And I'm sure many of you have had experience of joint external examinations, either having conducted them or been an evaluator. And also there is the SPAR, or the annual reporting, which happens every year. And these are meant to help us to strengthen our capacities as well as our ports of entry. Now, so this then brings me to the next part of my presentation. And this part of the presentation is about providing you with the example of how population movement and health affects a particular disease. And I think it's quite relevant if we have a look at Ebola, as this is on our minds at this time. and we can have some vignettes of cases and how they were controlled, but also have a look at how the establishment or the use of geospatial analysis helped establish what we call points of control in DRC. So just to give you a recap, as you can see here, the actual declaration of the outbreak was on the 1st of August, 2018, and this was in North Kivu, DRC. WHO have conducted a risk assessment, and these are online. You might find them in our disease outbreak news. And the risk assessment showed that the risk at national level and at regional level was very high, but globally, the risk was low. The analysis, as you can see, took into consideration a number of factors, and some of those are shown here on the slide. On the 17th of May, the Director General declared the event in DRC to be a public health emergency of international concern, as advised by the WHO Executive Committee for Ebola. Now, as of 2 days ago, we have over 3,000 cases that have been reported to WHO with Ebola virus disease. This map, and you're going to see a lot of maps from now on, this particular map looks at DRC, as you can see in the center there, with the purple or violet patches indicating density of population. And as you can see, there's a very large concentration of the population towards the border with Uganda, as well as Burundi and Rwanda. And again, they also have large concentrations of population on their sides as well. Now, the 4 countries closest, so South Sudan, Uganda, Rwanda, and Burundi, those 4 countries have been prioritized by WHO for operational readiness and preparedness activities. And in essence, this means that WHO and its partners are investing in ensuring that these countries have the capacities to be able to respond to a case of Ebola virus disease should it cross their borders. This is an epicurve just to illustrate to you where we are currently. And you can see we appear to have gone past the peak of the outbreak. However, we do remain vigilant and we cannot be complacent. There are sometimes issues with contact tracing, or we identify a case and we cannot identify all the contacts. But as of the 29th of October, we have 3,152 confirmed cases and over 1,000 probable cases. The majority are female, it's about 56%. This map is just to show you the current distribution of cases close to the border. As the number of cases has diminished, we are seeing the sort of regression of cases now back to where they originally started from, or where they originated from, and this would appear to be good news at this stage. The next slide needs to be clicked on, please, in order to demonstrate a evolution of the outbreak. Not sure who's controlling it. You just need to click on the slide to show. No. Go back. Okay, maybe it's not working. No, they need to. It's got a time lapse on it, so I wanted to show the evolution of the outbreak. But that's fine. I'll just talk. Maybe it's not working. I'll just talk to the slide. So the evolution of the outbreak, if it had worked, you would have seen the various cases that we've had. Okay, there we go. It's now working. And so you can see the evolution of cases that have been reported. And what we have seen throughout this is the movement of individuals and families within the country and also traveling across the borders. And these have contributed to the spread of the outbreak. These high rates of movement of the cases as well as their contacts continue to spread the disease from areas where they have originated, as well as to reseed areas from which the disease has previously been cleared. Some people travel while symptomatic, others are of course, traveling and are asymptomatic and or are incubating. Clearly those who are symptomatic are those posing the highest risk, and while they're on the move, they can spread this to various other people, and we have clearly seen this. So knowing this, having all this information, we actually do need to use it in order to plan and inform a sound analysis of how population movement can influence where we position our interventions. Okay, and so with regards to the IHR, which I'll go back to just for this particular slide, is that the IHR emphasizes public health measures at points of entry. But as we have just seen on the previous slide, people are moving both internally as well as externally across borders, avoiding points of entry. And so therefore, or at least avoiding designated points of entry. And so therefore, in this context, population movement takes place and is much more complex than just people passing through the regulated points. And in many parts of the world, communities living on either side of borders are actually linked socially or culturally. They're also linked by trade. And sometimes borders are very porous. There is no barrier, so people just walk across and visit their family who are actually in another country, but this is actually not recognized by the families who are split by this political or administrative boundary. So this particular slide, so the map is a map of DRC, and the part that has been expanded shows the points of entry, which are located close to our priority countries. There are, in DRC, 165 official border posts. However, only 18 of those are designated as points of entry under the IHR definition. Now, population movement occurs across the border between DRC and neighboring countries, and much of it takes place bypassing those border posts. So if we can identify the actual areas or the places where people are moving and trying to bypass the designated points of entry, then this can help us in regards to where we place our interventions. And this is another map which then shows you how people are traveling within DRC. The blue line is a river, and the line, the sort of reddish line, is a road. And so what we have found using a participatory approach is that people, yes, they travel by air, but a lot of them travel by road and then go by river to Kinshasa. So the arrows you can see are from Kinshasa to the areas where we have had Ebola virus cases detected, and also going the other way. So it's not just one-way traffic, they go both ways. And it's, people, again, they can take direct flights or indirect flights to go to Kinshasa or to go to these Ebola-affected areas. So how do we then try to use the knowledge that we have about population movement in order to apply interventions which can actually help us with regards to preparedness and response? So this is a slide which looks at an exercise which was carried out called Population Movement Mapping Exercise. And this was carried out by WHO, IOM, and the national border for health population in DRC. And the main method was a participatory method, so involving multi-sector key stakeholders from health, non-health, informal as well as informal people participated, so local people as well as various public health people, epidemiologists, clinicians, NGOs, key workers for other agencies. They all participated in identifying the routes that people took for either travel or trade which were not taking them past designated points of entry. And this is actually really, really useful because when we do this, we can actually identify points where we can post what we call points of control. So where these can be posted in order to apply useful interventions which can help us with this particular disease. And what we can see in the next slide is this just represented diagrammatically. So the population movement involved mapping and also involved some epidemiological evaluation. Now that epidemiological evaluation applied to the epidemiological profile of the individuals that were being identified as travelers. And so the reasons why they traveled and various other risk factors were all taken into consideration in order to then say, okay, we will set up these points of control, or we will strengthen points of entry, and at those particular posts, we will then carry out health screening. So health screening was the initial activity which was carried out, and that health screening basically involves taking people's temperature. This we found actually is not particularly effective because, of course, if people are asymptomatic or incubating, it might be difficult to identify that they actually have or may potentially have Ebola. And so on top of that, there was observation of the person, as well as asking people who were passing through these points to fill out health questionnaires. And so so it was a three-pronged approach: fill out a health questionnaire, have your temperature taken, and also be observed by the staff at the points of entry. And this again, once this system was in place, we were then able to support the identification of people who had been lost to follow-up with regards to contact tracing. And so these people were also then pulled aside and tested for Ebola virus disease. These points of control also provided an opportunity for risk communication as well as for community engagement as well. And so to help people to understand what Ebola virus disease was, the various risk factors that there were, and the measures that they could take in order to protect themselves. So using the methodology of population movement mapping, 106 points of entry and points of control were identified which required strengthening and would support the identification of potential cases of Ebola virus disease. So these were set up as a priority, so these were prioritized, and as I've said, there were a number of activities which were implemented as a package in each of these. Since August 2018, up until the end of this month, we have had over 3,000 alerts from these points of entry and points of control. 28 of those alerts resulted in the identification of cases of Ebola virus disease. And this included travelers who were symptomatic and people also not having fever. And this is quite important because, as we know, fever is one of the symptoms that we are asked to look at in order to identify a person with Ebola. So this particular map identifies, well, at least helps you to see who those 28 people were. When you look at 12 to 20, so 12 to 20, those represent people who were stopped on the DRC side trying to go through to Uganda. And the alerts are the ones where you can see in the green pentagons, and the identified 28 cases varied between males and females, you can see, and the age groups varied as well. And I have a particular case that I will then also show you as well. So this one, some of you may be familiar with. And in this particular situation, you can see 4 red dots, and these are all in DRC. The blue line is not a river, that is the border between DRC and Uganda. And so the red dots are on the DRC side. And then the yellow arrow is the route of travel of this particular group. And so what happened was a mother and her ill 5-year-old son, they tried to cross the border from DRC to Uganda via Kasindi, POE, but the staff based there asked that they stay and be evaluated. And but they were informed by the mother also that there were other ill relatives staying in a house nearby, and that they had arrived from Mabalako, which is a known active area of EVD, and they wanted to move on to Uganda. So the border staff went to the indicated house to investigate and found 8 other symptomatic individuals, and including the 5-year-old child, that made 9 altogether. And they screened the 14, including the mother. All symptomatic individuals were transferred to the Kasindi Hospital for temporary isolation, while referral to Beni was being arranged. Now, because of the security situation, the ambulance to take them to Beni would not come during the evening, and so therefore they had to wait until the next day for that to happen. And during that time, the mother, the 5-year-old child, and other members of the group crossed the border at another place. And so they left the place where they had been told to stay and await investigation, and they crossed the border at another place. And you can see that indicated by the orange star. Now, the community in that particular area were the ones who notified the border control officials about this particular family crossing over at a place that was not a point of entry. And so, as you know, that 5-year-old child was the first identified case of Ebola in Uganda. This is another illustration, and this slide shows the travel itinerary of the first Ebola virus disease case in Goma. And this person traveled from Butembo, where there was an ongoing outbreak, was initially symptomatic in early July, and then traveled to Goma via bus and arrived on the 13th or 14th, and then was diagnosed on the 14th of July with Ebola virus disease there. Now, clearly what we have is mapped out this person's travel, and in doing so, we are then able to have a look at potential points of contact or where he may have come into contact with other people. He traveled by bus, and so again, we were able to identify those people who were on the bus as well. Thankfully, there was no secondary transmission, and all those contacts that he had passed the 21-day follow-up without incident. Now, clearly, this scared a lot of people, and so Goma is well connected to other parts of DRC as well as Rwanda and Uganda. And what this slide shows is we try to then estimate how many people actually passed through Goma or areas around Goma. And we found this place called Petite Barrière is has over 40,000 passengers per day passing through it, going both ways. And so clearly, when you look at this volume of traffic, it's really, really difficult to be able to control, and we really do need to actually increase our resources and our training in that particular area. Okay, not much more left. 2 more slides. So public health action points. So what are the public health action points arising from this particular exercise that we did, particularly in DRC? So doing this mapping was really, really useful in that it was able to inform the allocation of financial, human, and resources for EVD preparedness and response. And so therefore, supporting decision-making has been really useful using geospatial analysis. We are able to identify priority points, both points of entry as well as the establishment of points of control, and those points of control being more internal, and the points of entry being the ones which are international crossing points. And then also involving the communities in the identification of the places where people and trade move. And so this then enables us to get their buy-in to the process, as well as identify the actual routes that people take, and so we are not putting resources into places and wasting them. However, significant challenges remain, and as you can see there, conflict continues in those areas, making it difficult for us to identify cases as well as to do contact tracing, and then also EVD fatigue setting in as well. It's now over a year, but we just have to continue to be vigilant, and also continue to support the various communities that are affected. And then my last slide. And so just in summary then, so we have this spread. Spatial analysis can help, as we've seen from the knowledgeable John Snow, and then also to our current use of GIS as well as other tools to help us to map out cases as well as geographic areas that are being affected. We are very clear that population movement contributes to spread and amplification. And again, this is nothing new, and it's something that we are all aware of. And then finally, geospatial analysis really can help to increase our understanding, increase our ability to make decisions, and maybe for FETP fellows in the audience, this may be, and also to directors of programs, maybe GIS is something that you could consider including in the curriculum. Not everybody will become a GIS specialist, of course, but this is then a way for us to help ourselves function better, as well as when we go to communities, we can then be able to map out where our potential hotspots are, be more efficient, and also to save resources. Thank you very much. Some acknowledgements. Thanks.
I'd like to thank Dr. Olowokure for what you will agree was a fascinating panorama placing epidemiology in the context of history, geography, anthropology, and clearly a lot of work went into this presentation to give us the insight that it has provided. I'd like to invite questions from the audience. I see Professor Martin Kirk is already at the mic, and I think it's Germain behind him, I'm not sure. Okay, please, Martin, go ahead.
Thanks very much, Dr. Olowokure. It was a really fantastic presentation. And really great to see how GIS is being used in the response. I was interested in the way, the use of GIS and the border screening in picking up contacts that were lost to follow-up inside DRC. I'm wondering, was that a database based follow-up, or was that a manual process about contacts were lost to follow-up? And it's obviously a lot of work doing the border screening. So if what I'm trying to ask is, did they use a database where they had contacts that were lost to follow-up and cross-checking, or is it a manual process?
Thanks, Barty. So initially paper-based, but has now evolved and is now more computer-based, allowing the contacts to be identified when they present ID, and therefore you just check the database and you can see whether their names appear there, and then you know that that's a contact who's been lost to follow-up, and then you refer them for follow-up. Thank you.
Thank you, sir. I'm sorry. I'm
Too
okay.
tall.
Okay, thank you, sir, for your excellent presentation. I'm Jermaine Bukasa Kazadi. I'm originally from DRC, but I live now in Canada. I have just a small question. Today is November 1st. I just look at the update. There are 3,200 people confirmed or suspected case of Ebola in Congo. From this number, survivors are only 1,052, which means almost 65 of people confirmed or suspected passed away. This is a huge, this is a very dramatic situation. My concerns are about some of the risk or factors. I appreciate the analysis you have made on movement of population. However, there are just two things. Trust. People, they don't trust not just the system, even their own leaders. There are several things need to be done at that level, and safety. Why we can see the other side of the border? We had one confirmed case in Uganda, and a few days later, this spread has been even stopped. But in Congo, it's still continuing. Mainly, we need to. I understand that participatory approach is good. But when I look at your analysis, I don't know if you can make this slide. You can see about the output, the outcome, and what we have done. So I have seen community engagement in a second. I don't know if you can go back, and then I can.
Yeah. I know which slide he wants.
Is it possible to go back to
the slide where you talk about
Can I go back?
outcome, output?
25.
I don't know if you can go back.
Is it possible to link the presentation in again, please?
It's okay. Anyways, but the thing I would like to say, community engagement, we need to work on that, because the people, Congolese people, lost the trust. And this is a very unstable area.
Okay.
It's not just now. It almost since Congo became independent. So I may suggest this. To participatory approach is really good, but you need to engage people, local people, to build the trust, to work with local people, and then maybe, and engaging people the other side of the border. I think this is one. I know epidemiologically speaking, we cannot.
Next one.
It's not easy to do that, but yes, here I go. So you see,
Thanks.
after risk communication is good. Communication engagement is good, but community engagements must move even on the top. I would suggest this being one of the things need to be a priority. I think that's one way to engaging people to regain the trust. The trust is lost. Even if you tell people you don't move, but as long as there are people telling them, there are several things. I know there are several things about movement of people because they think they will be displaced to go somewhere else from their, land. That's my small comment. Thank you.
No, thank you very much for that. I think your points are well taken. We have recognized that community engagement is really, really important. These are not in order of priority, so please don't assume that community engagement is at the bottom because it's the least important. These are all equally important. We cannot move forward or we cannot progress unless we address all of those factors and maybe more. I think it's also sometimes it's about how we engage the community. Yeah, and that has, in the initial days or initial months of the response, that could have been better. But we are learning as we are going along, and I think the response now is much, much better. The engagement with the community also has improved a lot, and they're becoming more involved in the response as well. So your point is well taken, and I think it's something we are addressing. Thank you very much.
Hello, I'm Rebecca Merrill from US CDC.
Okay.
Hello, and
Hi.
thank you for your excellent presentation. I focus a lot of my efforts on understanding population movement at and helping to use that for public health interventions at the community level and systems level. And so with this opportunity to have you up there, I'm curious if you can comment on innovations that we could all work towards to help make that process more efficient of gathering information from the community level and really integrating it into strategies for preparedness and response.
Thank you very much. I think from my particular perspective, sure if we can call them innovations, but it is the appropriate use of health systems and also the potential application of tools such as GoData, which collects information on contacts, and then trying to integrate that with the health system itself, databases. And so in that way, we can then try to ensure that we identify the appropriate contacts as well as the cases. Having said that, sometimes people use different names, and or there is mistranslation of the name or the age, and so therefore then it makes it a little bit more difficult for us to be able to actually identify that person. But I do think GoData has a lot of potential for this, and I do believe that if we can use that tool appropriately, it will help us a lot better. It's actually being implemented in DRC as we speak, and so therefore we can discuss this after the talk before your session this afternoon. Thank you.
Hi, I'm Raquel, a fellow from the European CDC, and this is a really interesting presentation, and I wondered if you can give us advice regarding us as public health professionals. What can we do to ensure that this information about the risk of introduction of pathogens associated to population movement, how can we ensure it doesn't get misused by the media, by political groups, by certain population groups that use this information to reduce and restrict freedom of movement of migratory groups. So I work in Malta and I am from Spain. They are two of the main ports of entry for refugees and asylum seekers in Europe. And I have experienced firsthand, pretty much every day, how this information that is very important, that migration might contribute, or population movement contributes to the spread of infectious diseases. This information gets used on a daily basis to fight this freedom of movement and to increase xenophobia. So what can we do as public health professionals to reduce this?
I'm not sure if I should thank you for that question. It's a very difficult question to answer. But I think as public health professionals, we need to stay true to our principles, which is we provide the evidence, we communicate that with the appropriate risk levels around it, and also ensure that we as public health professionals continue to advocate for vulnerable people. This is really, really, really important for us as a group. This is what we can do. I think we have little or no control over how the media will then spin whatever it is that we say. But as long as we continue to provide facts and evidence and continue to support the underserved, I think this is the best we can do at this stage. Clearly, advocacy at the highest level as well, and so therefore advocating to politicians to ensure that they are well aware, provide them with briefings as often as possible on the situation on the ground, so again that they are aware of what is really happening rather than them reading on in newspapers or on the TV something that is being spun by the media or by other politicians, because very clearly this is of interest in some ways, as you say, to restrict migration of people from across borders. Thank you.
We can take the last question from Nyambe.
Thank you very much for that excellent presentation. My first question is on the mapping of new settlements, taking into account the humanitarian crisis and the continued fighting. I don't know to what extent we are taking account of possibility of people moving within the DRC into new settlements, and how are we taking account into, how are we mapping those new settlements and resonating that data with probably new infections and possibility of spread. The second component is we've invested a lot in understanding the movements in the P1 countries, the ones that have been highlighted, I think, in the map you showed. But to what extent do we have evidence of movement in the P2 countries? For example, Zambia, we have a huge lake, Lake Tanganyika, that connects DRC to Zambia, and there's a lot of fishing and a lot of movement. And if you check some of the evidence from the refugees in our books, you get alarmed at the high number of people that actually come into our country as well. This could be similar also to other countries. But to what extent have we invested also in understanding the movement in P2 countries to inform decision-making in terms of investment in preparedness and response? Thank you.
Thanks very much. So maybe the two questions are quite related. In fact, what WHO has done is institute preparedness and readiness activities in the 9 countries, but focusing mainly on those 4, so the B1s, and also implementing activities in the B2s. In order for us to identify people who may be affected who are traveling, there are places where people are, people are placed in camps, or the displaced populations congregate in certain areas, and so therefore there is strengthening of surveillance in those areas as well. And so the packages that were displayed for the points of control and the points of entry, those are also being used in various camps where displaced people are in order to identify potential cases there. To my knowledge, I don't think any have been identified at this time. I think one of our concerns has always been that the borders are very porous in that particular, given the situation that we are in. And people still need to travel to visit their families, or they need, as you say, to go and fish for their own livelihoods as well. I think it's, again, the points of control. None of them are in Zambia, but I understand that the points of entry there have been strengthened. And so that means that, again, those packages where people are screened when they arrive are in place, and also that there is the ability to call on WHO should there be a case which arises within those particular countries. Thank you very much. So before I finish. So just before I finish, I would just like to acknowledge that I am doing this talk on behalf of a group of people who contributed to this particular presentation. And they told me that they're going to be watching me live to make sure that they pick up, and they'll be sending me emails just to make sure I've told the truth, the whole truth, and nothing but the truth. So thank you all very much for your attention. Thanks.
So thank you so much, Dr. Olowokure, for a very good presentation, and thank you all for your attendance and participation. we can break now for coffee. Thank you very much.
Mm.